Axillary nerve. The axillary nerve is a terminal branch of the posterior cord of the brachial plexus and derives fibers from C5 and C6. Coming to its course, it arises as a terminal branch from the posterior cord of the brachial plexus. It leaves the axilla through the quadrangular space, along with the posterior circumflex humeral artery. It gives an articular twig to the shoulder joint before dividing into anterior and posterior branches. The anterior branch continues horizontally between the deltoid and surgical neck of the humerus and supplies the deltoid. The posterior branch supplies the teres minor and the posterior part of the deltoid. This is its motor innervation. Then it pierces the deep fascia to continue as the upper lateral cutaneous nerve of the arm. It supplies the skin over the lower half of the deltoid and is its sensory innervation. Through the action of the deltoid, the nerve is responsible for shoulder abduction. However, the anterior muscle fibers cause flexion and medial rotation of the shoulder, and the posterior muscle fibers cause extension and lateral rotation of the shoulder. Through the action of the teres minor, it is responsible for lateral rotation and abduction of the shoulder. Now coming to axillary nerve injury. This causes both sensory and motor deficits. Injury is usually caused by two things: an inferior dislocation of the humeral head. This is due to the fact that the axillary nerve courses inferior to the shoulder joint. A fracture of the surgical neck of the humerus. This is due to its course around the posterior aspect of the surgical neck of the humerus. Injury to the nerve will result in the following: loss of horizontal abduction from 15 to 110 degrees. This is due to paralysis of the deltoid and teres minor muscles. Atrophy of the deltoid. This may lead to loss of the rounded contour of the shoulder. And lastly, loss of sensation on the skin of the cap of the shoulder. This is due to involvement of the upper lateral cutaneous nerve of the arm.